Ma'am, we are live.
We're live? Okay. Yeah.
Okay. A very good evening to one and all present here. On behalf of YOSI, I welcome you all and thank you for being a part of the Journal Club for the month of February 2023. The Journal Club has been an effort by the Governing Council as well as the executive body. And on behalf of YOSI, I would like to thank all of them for making this a continuous endeavor where all of us can be a part of it. There, you had the Governing Council, and this is the executive members at YOSI. So the concept of the Journal Club was a method in which young ophthalmologists, PG residents, fellows could learn and grow from their immediate seniors, whereas an article which was published could be dissected, could be treated as a learning experience for the young crowd. So in a Journal Club, we assess the current literature, where we define and we talk about the problem. We specify the research question. We define the variables. We define the selection of the subjects. We formulate an appropriate research study design. We analyze the data and finally interpret it according to the Mary format, which will be elucidated going forward. Taking all this into account, we formulated a specific format for a Journal Club, in which at the beginning of every month, we usually have a call out for mentees who would like to be mentored by a senior member at the YOSI panel. The mentee undergoes a month-long training with the mentor, where a journal is selected by the mentee and the mentor together. And the mentee is trained into reading the journal, analyzing the journal, and understanding the positive and the negative aspects, and learning how to present such a journal in a journal. On the final day, along with the mentee and the mentor, we always have an expert panel, which usually tries to dissect the journal further and talk about recent advances. Another very interesting aspect is the research expert who dissects the journal from a statistical point of view. Thus, we have a very wholesome effort put into every session. Like mentioned before, we have the Mary format, where our journal is dissected according to the method, the assignment, the assessment, the results, the interpretation, and finally the extrapolation, where a step-by-step approach is implied. This is the current team for YOSI JC, mentored by Nupur ma'am, and the rest of the team is here as follows. If you are a part and an audience in today's Journal Club, you enjoyed the Journal Club and would like to participate in a further session, you can take a screenshot of this page and email us at yosi@journalclub@gmail.com and be a part of the next Journal Club. So from our first ever session on glaucoma, which was now almost 1.5 years ago, we've had sessions on endophthalmitis, cataract, ocular oncology, pediatric ophthalmology, oculoplasty, glaucoma once again. And then we moved on to a much more formatted version of it, where we again had pediatric ophthalmology, retina, refractive, cornea. And that brings us to today's Journal Club, which is the starting of a new year, where we again go through all the subspecialties once again. And it just so happens we are starting off with cornea once again. So as you can see, this is a long effort that has been put on for months and months, leading to a culmination into today's Journal Club. So the article that we are discussing today is from the Indian Journal of Ophthalmology, and the article reads, Amniotic membrane transplant in acute ocular surface burns in Western India, a tertiary eye care center study.
Hey, মুখে হাত দিচ্ছে কেন?
I'll just mute, just requesting everyone to be on mute. The impact factor of the journal, that is the Indian Journal of Ophthalmology, is 1.848 currently. Joining us for today's Journal Club is our research expert, Dr. Rohit Modi, who's the director at the Centra Clinic. Our expert panel consisting of Dr. Shuchismita from Pune, Dr. Purvashan Narang from Nagpur, and Dr. Vineet Joshi sir from LVPI Hyderabad. As explained and as elucidated before, we have a mentor who's been working with the mentee for the entire month, helping the mentee understand the manuscript and understand presentation throughout the month. And this month, our mentor is Dr. Aditi Ghosh, who is from Delhi. And our presenter is I'm so sorry about the name. The presenter is Dr. Kirthana, and she's a second-year postgraduate from IQ City Medical College. And I will be a moderator for this evening. And without further ado, I would like to call upon Dr. Kirthana to please share her screen and start her presentation. Dr. Kirthana, yes.
Yes,
I can see your presentation. You can just put it on slideshow mode.
yes. Is the screen visible?
It's visible. You can begin.
Very good evening to the esteemed panelists of the Young Ophthalmologist Society of India. Today, I'll be presenting an article whose title reads Amniotic Membrane Transplant in Acute Ocular Surface Burns in Western India. This study has been taken from the Indian Journal of Ophthalmology and has an impact factor of 1.848. Now, coming to today's discussion, ocular chemical injury is one of the true ophthalmic emergencies which often results in significant ocular morbidity. Now, to keep the active participation of our audience as well, I would like to ask a few questions to both the audience as well as the panelists. So coming to the first question for the evening, which among the following classifications is most commonly used for ocular surface burns? There are 4 options. Option A, Roper-Hall's classification, B, Dua's classification, C, Schaffer-Weiss classification, and D, Hughes' classification. You can type your answers with the respective numbers in the chat box, and then we'll discuss further.
So we have a response already, Dr. Kirthana. Sarah says option D. So we'll just wait for 5 seconds before you reveal the answer. If there's anyone else, there is a Zoom user that says option B. So there is a conflict over here. I think Kirthana Di, you can reveal the answer.
Okay, so the answer is B, Dua's classification. And now we will discuss about this classification. So Dua's classification is graded from grade 1 to grade 6, and it tells us about the clock hours of limbal involvement as well as the percentage of conjunctival involvement in ocular chemical injury. For example, in grade 3, the prognosis is good, and it has more than 3 to 6 clock hours of limbal involvement and more than 30 to 50% of conjunctival involvement. The pictures on the right side of the screen correspond to each grade of the Dua's classification and have been given for your reference. The purpose of this study is to evaluate the outcomes of early amniotic membrane transplant in acute ocular surface burns using Dua's classification. This was a retrospective study of case records done between the time period of 5 years, between the years May 2014 to May 2019, at a tertiary eye care center in Western India in patients with ocular surface burns undergoing amniotic membrane transplant within 2 weeks post-insult. There were a total of 24 patients, and a total of 27 eyes were included in this study, out of which 19 were unilateral and 5 were bilateral at presentation. But 2 eyes were excluded from the study because they belonged to grade 1 of Dua's. Now, those patients who underwent amniotic membrane transplant within 2 weeks post-insult and belonged to grade 3 and grade 4 according to the Dua's were included in this study. And those patients who underwent amniotic membrane transplant 2 weeks after insult and belonged to grades 5 and grade 6 according to the Dua's were excluded from the study. Now, coming to the variables that were taken into consideration, it was the available records for age, gender, time of presentation to the study center, type of injury, whether it was accidental or assault in nature, the nature of the agent, whether it was acid, alkali, or thermal, the site of the injury, site at which the injury took place, whether it was occupational or household, and the laterality of the eyes. Now, at the study center, certain interventions were done. At first, the visual acuity was assessed, followed by certain clinical findings which were noted in both the cornea as well as the conjunctiva. In the cornea, they noted the presence of particulate agent, presence of any kind of epithelial defect, haze, melting, and infection. And in the conjunctiva, they looked for epithelial defect, blanching, presence of subconjunctival hemorrhage, necrosis, and symblepharon formation. Now, the treatment given to these patients depended upon the grade and the severity of inflammation. Those who belonged to the lower grades, according to the duas, needed only primary amniotic membrane transplant in adjunct to medical therapy. Some others needed procedures like tenonplasty, tarsorrhaphy, limbal stem cell transplant, along with primary AMT. And some others also needed keratoplasty. And in those patients where there was persistent epithelial defect, repeat amniotic membrane transplant in adjunct to primary amniotic membrane transplant also needed to be done. Now, coming to the second question for the evening, which among the following is the initial treatment given for any ocular chemical injury? Now, coming to our options, option A, thorough irrigation with normal saline or balanced salt solution. B, infiltration of local anesthesia. C, debridement. D, topical antibiotic instillation. Again, you can type your answers in the chat box.
So Sarah has already typed option A as the answer. So we'll just wait for another around 5 to 10 seconds. If you feel you know the answer, you can type it in the chat box. If not, we'll let Kirtanadi come up with the answer. I think Kirtanadi, you can go ahead with the answer. Dr. Pushkar Badani has also responded with option A.
Okay, yes, the option is option A, thorough irrigation with normal saline or balanced salt solution immediately on presentation. Now, coming to the treatment proper, at first on presentation under local anesthesia, thorough irrigation with normal saline or balanced salt solution was done with removal of particulate matter, following which visual acuity assessment, thorough slit lamp and microscopic examination, intraocular pressure measurement using either the digital or the non-contact tonometer, and in cases where indicated, even the posterior segment assessment was done, following which estimation of injury and assessment was done according to Dua's classification. Now, under local or general anesthesia, after written and informed consent, cryopreserved wet human amniotic membrane transplant was done in using fibrin glue or anchoring sutures in those patients who presented within 2 weeks post-insult. Debridement of the necrotic tissue or the retained agent was done along with procedures like tenonplasty or tarsorrhaphy, where indicated along with primary amniotic membrane transplant. And in cases of persistent epithelial defect, multiple layers of amniotic membrane needed to be transplanted. Also, all these patients received pre- and post-operative medications, both topical and systemic, depending upon the severity of inflammation and the grade of injury according to Duas. Some medications which were given both pre- and post-operatively were topical antibiotic eye drops given almost 4 to 6 times a day. Topical eye ointments were prescribed for once at night, at bedtime. Artificial tear substitutes were given on an hourly basis. Topical steroid preparations were given 6 times daily. Vitamin C tablets were administered orally. Cycloplegics and IOP lowering agents were also given. Also, in those cases where there was no contraindication, systemic doxycycline was also administered. Now, coming to the post-operative assessment of outcome, at first, symptomatic improvement in terms of improvement in ocular pain, watering, photophobia, and epithelialization of both the cornea as well as the conjunctiva were noted. Late outcomes were measured in terms of clock hours of corneal vascularization and symblepharon development, which was graded as mild, moderate, and severe. On complete epithelialization, visual acuity improvement of more than 2 lines from the time of presentation was noted as a positive outcome. Certain parameters were considered for outcome measurement. At first, age group was considered. Those who were less than 14 years of age were regarded as pediatric age group, and those more than 14 were regarded as adult. The type of agent causing the injury, the grade of injury according to Duas, the time of amniotic membrane transplant at which it was performed, and also the patients were divided into 2 groups, namely Group A and Group B. We shall discuss which were the patients who were divided into these 2 groups in our following slides. The data was analyzed using the statistical package of social science version 21.0, and a p-value of less than 0.05 was considered to be statistically significant. Now, coming to the results, we all know that there were a total of 24 patients and total of 27 eyes had ocular chemical injury, out of which 15 eyes were involved in group A, that is the moderate grade, wherein grade 3 and grade 4 of DUAs was taken into consideration, and 12 eyes were involved in group B, as in the severe grade, that is grade 5 and grade 6 according to DUA's classification. The average age of the patients at presentation was 19.85 with a mean deviation of 15 years, and the average follow-up period was roughly somewhere between 2 to 9 months in this study. The 15 eyes who were involved in group A had better results in terms of visual outcome, better epithelialization, as well as lesser amount of surface sequelae. This table gives us an idea about the number of eyes for the grades of injury involved with the type of causative agent. And in this study, it was seen that the maximum number of ocular chemical injury, irrespective of the grade, occurred due to alkali injury. It was seen that there was an association of corneal vascularization with the grade of injury, and it was found to be statistically significant, having a p-value of 0.009. Also, more cases of improvement was seen in the lower grades, that is grade A patients, group A patients, that is having a p-value of 0.041. I would like to mention here that one eye of grade 6 ocular injury went into phthisis bulbi and was hence excluded from the calculation of both the epithelialization time as well as corneal vascularization. According to this study, corneal stroma was seen to be more vulnerable to damage from grade 3 onwards, and it needed amniotic membrane transplant for the re-epithelialization of cornea. Certain comparisons have been made with other studies which seem to have similar outcomes. For example, in this group, the pediatric age group, that is less than 14 years of age, was seen to be affected more with Lyme, having a percentage of almost 75, which is comparable to the Vajpayee study, where the percentage was seen to be 65.6%. The epithelialization of cornea in this study was happened at 5.80 with a mean of 2.92 weeks, which is comparable to the other study, namely the Meller study, where it was seen to occur between 2 to 5 weeks. It was seen that the epithelial defect healing time was higher with a higher grade of injury, and in those who had that persistent epithelial defect, symplepharon lysis, as well as premature detached amniotic membrane, and this was an indication for repeat amniotic membrane transplant. Also, significant amount of visual improvement as well as corneal vascularization of less than 6 clock hours was noted in group A, and this was encouraging to perform amniotic membrane transplant in those patients who presented at the study center in the early phase of the acute stage. According to the author, amniotic membrane transplant alone had very little role in extensive limbal ischemia in the severe grades, that is grades 5 and 6, that is group B patients. But when AMT was done along with other surgical procedures like tenonplasty, tarsorrhaphy, and limbal stem cell transplant, it helped to maintain the integrity of the eye for future visual rehabilitation. According to the author, there were certain limitations in the study, which was the limited sample size, the retrospective mode of study with a short follow-up period. Also, no comparison with other classification systems was made, like, for example, with the Roper-Hall classification. And this study did not include the corneal epithelial defect size. So there could have been an overlap with the DUA's grading system while grading them into different grades of injury, indirectly causing more damage to the patients. Now, coming to the assessment of this article based on the MARI format, the study hypothesis, study design, study population, the study period, and the sample size have been defined here. The method of assignment of study population, also the study variables are defined, but the average follow-up period for moderate grade and severe grade of patients is not mentioned. The measurement of outcome, both in terms of both symptomatic improvement in the lower grades and in terms of corneal vascularization and symplepharon formation in the higher grades, has been appropriately done. But limbal staining would have been more evident than limbal ischemia for interpretation in this study, because when the patients presented primarily at the study center, ischemia would have often been masked due to the widespread chemosis as well as presence of particulate matter. Also, as already mentioned, Dua's grading system does not consider the corneal epithelial defect size. Now, this table summarizes the result, and we can see here that visual acuity has improved in the group A patients, that is those patients who belong to grade 3 and grade 4 of Duas. And this is the conclusion that we draw from this table. And this was possible only because these patients presented to the study center early on, as soon as the ocular chemical injury took place. It was seen that lime was the commonest agent among the alkalis to cause burns. And also there is an association between corneal vascularization with the grade of injury, but not with the type of agent which caused the burn. Also, long-term follow-up for the final outcome measures is required and could have been done, as eyes with ocular chemical injury do have a potential for both cosmetic and visual improvement later on in the chronic stages. Extrapolation of the results could not be done for all populations because lower grades had undergone only primary amniotic membrane transplant, whereas higher grades needed certain other procedures like tenonplasty and tarsorrhaphy, as already mentioned, along with primary AMD. According to my interpretation, a definite follow-up period is nowhere mentioned for all patients except that all of them were followed up on post-operative day 1. Also, outcome in each case may vary according to the grade of injury and the additional procedures which were done according to the severity. So a bigger sample size with a defined treatment protocol for each grade would have been better for result calculation in my opinion. These are a few references for the statements and for the studies that have been quoted here in this article. And now I have come to the end of my presentation. I would like to express my special thanks to my mentor, Dr. Aditi ma'am, for her valuable time and effort, without whom this would have not been possible. And also I'm deeply indebted to Dr. Anujit for his support and understanding from ever since this journal club was assigned. Thank you very much for your patient hearing.
Thank you so much, Dr. Kirthana. That was indeed an excellent presentation and very lucidly explained and a very lucidly dissected version of the entire manuscript, which is usually quite daunting for first-time readers to go through. I'd request you to just stop sharing your screen so that I can introduce the next panelist.
Yes.
Thank you so much. I'll just share my screen. And while doing so, I would like to invite Dr. Rohit Modi, sir, to appraise the article and give his thoughts as the research expert this evening. Dr. Rohit Modi, sir, is a trained vitreoretinal specialist with special interest in biostatistics. He is also the director at the Centra Clinic in Mumbai and an avid member and an active member of the YOSI Journal Club. Sir, I'll just hand over the mic to you.
Yeah. Thank you, Anujit. And thank you, Nupur, for this wonderful opportunity. And well, the clinical relevance would be better described by a cornea specialist. I am speaking as a pure vitreoretina specialist, so if I make any errors, even in basics, so please forgive me for that. And but I'm just going to speak about the pure statistical aspect, what I found. Couple of things, when we look at the abstract part, the abstract says that it wants to evaluate the outcome of early amniotic membrane transplant in acute ocular surface burns using Dua's classification. And, when we read the conclusion or the last statement in the results, they have actually compared the two groups. So the study question needs to be well defined, when we are talking about that, and it needs to be very specific. They could have actually said that, the outcomes of amniotic membrane transplant in, comparing various grades of ocular surface burn, something of that sort. So it would have been great if they can, the study can define the primary outcome measure as well as the secondary outcome measure. Another thing which I found out was that when we read the article, they have mentioned which software they have used and what level of p-value they consider as statistically significant. They have used SPSS and a p-value of 0.05, but they haven't mentioned which statistical test they have used. And that is going to be very important. Now, when we look at the results, the two statistically significant results which I came across, one was the degree of corneal vascularization with the grade of injuries. Now they have used association. They have said that if the degree of the grade of burns was severe, the corneal vascularization was more. So they need to specify which association test they have used, whether they have used Pearson's or Spearman's, because that again has a bearing on the p-value. The another thing which they have mentioned is the mean epithelialization time in group A versus the mean epithelialization time in group B. Can I request Dr. Kirthana to come with that slide? I just want to show an interesting data on that.
Yes. So which slide exactly?
I do not know the number, but in this the results one, in which we are talking about the mean epithelialization time.
Yes, just a minute.
Table 3, Kirthana.
Yeah, Papu, the result. Huh? Yeah.
Now, yeah. So, when we look at the mean epithelialization time, they have said that statistically it is significant, and we can see here they have mentioned the mean plus or minus standard deviation. Now, the total number of eyes taken in this study is 27. If the sample size is less than 30, then we assume that the data is non-parametric and we're going to use a non-parametric test. So for non-parametric test, medians are better than means. I'm actually assuming they have used a parametric test because they have given here mean plus or minus SD. They have not given a median value. Now, when we apply a parametric test to a non-parametric data, there is a possibility that even a non-significant data will get a significance. Whereas if we apply a non-parametric test to a parametric data, then the chances of a false positive outcome coming out is much lesser. So assuming since the authors have used mean plus SD, they may have used a parametric test. So if they would have specified which test to be used, that would have been great. Again, having said that, I realize that ocular surface injuries are not that common. So to have such a wonderful follow-up with documentation of a decent number of eyes is commendable. So no offense meant. I just was speaking with just respect to statistics part. So those were my key points. So study questions could have been much more well-defined with the present data itself. And with the present data itself, they could have also specified which test they are using.
Thank you so much, sir. As usual, hitting the nail on the head every time. Kirthana ma'am, I just want you to stop sharing once again so that I can introduce the next panel member. Thank you. I would like to call upon Dr. Vineet Joshi. Dr. Vineet Joshi, sir, is an alumnus of Krishna Institute of Medical Sciences, Pune, and he did his internship from DY Patikal Medical College, Pune, and then his residency from Shankaraya Hospital, following which he underwent a clinical research lab fellowship at PGI Chandigarh, and then a 2-year fellowship at LVPI Hyderabad, where he is currently, and he has many areas of interest in cornea and anterior segment, as well as interest in training and mentoring young doctors like us. And I would invite Dr. Vineet Joshi, sir, to talk about the positive aspects of today's research paper. On to you, Vineet, sir.
Hi, Thank you. Thank you. Very nicely presented, Kirtan, and really amazing points, Dr. Rohit Modi. Actually, really, as an these points actually we tend to miss out, but very rightly pointed out, especially the median part with the non-parametric test. So the power of the study is also needs to be explained. So what I see here is that I will, before I jump onto the positive aspects, let me just give you a gist of it, is that probably here we tried to evaluate a lot of things, but with a limited data set. And so this paper, what it identifies is that for private practitioners, who are the first doctors who come across with the patients with chemical burns. So what to do? It's a big question, whether you put amniotic membrane grafts for all the patients or you don't. Is there something to prove that this can work for every single patient or not? So some of these questions were answered in one of the recent ocular surface workshop, and I will bring out those points, and I think Dr. Purvesh Naran will also bring out those points. But this is a very nicely done study which highlights the use of amniotic membrane transplant. We already know its benefits, but its advantage to prevent vascularization and to prevent similar front formation. And I won't say obviously in this study, if you see that they didn't see much success with the higher grades of injuries. What I want to tell you is that grade 3 and grade 4, yes, definitely the results were seen. But when you talk about something like grade 5 and grade 6 injuries, there are a lot more factors into play. Other than just epi defect or limbal ischemia, or so the injury caused by alkali is extremely important point here. Now, what happens in most of these grade 5 and 6 patients is that they have burnt out beyond the capacity of any single modality of treatment to heal. So in those cases, you actually need a multimodal therapy, right from medical management with steroids, which has to be actually pumped up for probably a longer period of time. And then you need many supportive measures, and amniotic membrane happens to be one part of it. So if we are trying to see here that amniotic membrane is the main thing to treat grade 5, grade 6 injuries, that would probably not the right way to look at these injuries. They don't behave the way we want them to. Even if you do multiple amniotic membrane transplants, sometimes they will not respond, especially when you have in alkali injuries where you have not removed the residual lime. Even if it is smallest of particles stuck into the deepest of fornices superiorly, will not allow the epithelial defect to heal. I'm just going to switch to my mobile because my laptop's going to die of battery. So just give me 1 second.
Sure, sir, not a problem.
Yeah. Hi, sorry. So, can you hear me well?
Yes, sir, that was too quick.
Okay, yeah. So what I really wanted to highlight was that it's a very good attempt, very nicely done study, and I think this will help a lot of private practitioners to understand what to do if they are the first person to face these patients. Okay, so and I think what they could have done here is probably also included a group of controls, although it is ethically wrong to have a control in a study like this where it is acute chemical injuries, because you cannot justify a control, but rather you could have they could have probably just seen patients who have not undergone amniotic membrane transplants and who were of the grade 3 and grade 4 category, and how they actually healed over a period of time. That will give probably a better understanding as to what the amniotic membrane does and how does it prevent these kind of injuries worsening, because it's important to understand that what does it mean by improvement, what does it mean by having a better outcome in these cases. So when you are having a grade 5 and grade 6 injury, having probably a milder grade symblepharon is a very good outcome, and probably having say 6 clock hours of vascularization or 4 clock hours of vascularization is probably a good outcome, because the worst outcomes are where you get a total LSCD and total corneal vascularization, and with probably very fleshy symblephrons forming throughout the inferior fornix, and that can lead to very bad outcomes. So it's very important to understand the whole clinical spectrum. So I think amniotic membrane is one part of the whole picture, and it definitely helps decrease the overall severity of the outcome of the disease. And yes, that is what this study highlights, that it will decrease vascularization and also help improve visual acuity in some cases. What I would like to bring to light here is that something that we found out recently. So with a small, I think Aditi's mic is on. Okay. So recently, what we did was we actually worked with a group of engineers who were actually image processing and data scientists working in AI in IIT, and we tried to solve a problem, which I think Purvasha will touch base on in her aspect, is that do you really need amniotic membrane in all the ocular chemical injuries? Because there is something which the medical treatment also is important, and it has a certain aspect. So because usually we being a tertiary center, we don't get too many patients who are within the first 1 week, 2 week time point. So most of them are basically beyond the 2 week time point. And there it is a real dilemma where what do you do? Whether you put an AMG or you don't put an AMG. So what we did was we actually made our own grading system just for the sake of training an AI algorithm. And we actually found that the corneal epithelial defect, the corneal visibility, that means the texture of the cornea at the time of presentation, its visibility to see the anterior segment structures, and the ischemia were actually better pointers than any other factor like chemosis, hemorrhage, or anything. And we just took diffuse slit lamp photographs to train that algorithm. We found that these three factors were actually key to give you an idea whether amniotic membrane would be needed or a surgical intervention would be needed for that patient. So yes, I mean, very nicely done study, and I think Dr. Purvasha will explain the negatives of this one.
Thank you so much, Vineet sir. I think including the practical aspect as a private practitioner, how this would benefit them, especially after interpreting the study, is something that was very important to bring to light. With that, I just would like to introduce the next panel member, Dr. Purvasha Narang, ma'am. Dr. Purvasha Narang is an associate professor at AIIMS Nagpur, and she has completed her fellowship in anterior segment and training in cornea and refractive surgery at LVP Hyderabad. She is also an ex-faculty member at NGIMS and a senior consultant of cornea and ocular surface at LJI Institute at Ambala, with special interest in cornea and limbal cell transplantation, ocular surface reconstruction, and ocular microbiology, as well as the fact that she's a reviewer and an associated editor in many peer-reviewed journals. And today I would like to invite Purvasha Narang ma'am to speak about the negative aspects of the manuscript. Over to you, ma'am.
Thank you so much, Anujit. And at the outset, I would like to thank YOSI for this opportunity to be invited to this esteemed panel of the Journal Club. And congratulations, Kirtana and Dr. Aditi. You've done a wonderful job, and this overview was excellent and it was very nicely discussed. Too good for a first timer. And thank you, Dr. Rohit, for the elaborate clinical the discussion on the statistics. Even though you are a retina person, I'm sure you must have felt the pain of the ocular surface burns. And thanks, Dr. Vineet, for your positive points on this article. Indeed, it is a very good article as far as the data that has been brought about, and it has been published in 2021. And it was long due that we have some very substantial data where we all know that amniotic membrane does help in the ocular surface burns by acting as a biological bandage, and it has decreased chances of the inflammation where your inflammatory cells that have migrated, they are autophagic or they are apoptosed, and there is decreased neovascularization. There is presence of all the good factors which are there. It promotes epithelialization. It helps in supplying the substrate for the layer to form, the epithelial layer to form of the deranged stroma. And also there is some amount of antibacterial effect to it also. But clinical data was lacking, and there are now studies which are substantiating this. And this is one very good study, especially because this is it's an important topic because it's an ocular emergency wherein different areas present with different kinds of burns, and the demography is different. As we have seen over here, it is more so in children. There is Lyme burns. Then there are other types of thermal burns as well as chemical burns which have been included, which I think is a little this thing we could have just studied. Just coming to trying to get to the negatives of the study was they have included the thermal as well as the chemical burns. And we know that thermal burns are very severe because they cause increased inflammation. They have this added disadvantage of having a high temperature associated and more prone to being infected. So I think thermal burns have a very poor prognosis as compared to chemical ones. And if you look at the other aspects, they have mentioned that 27 eyes have been included, and there were 5 bilateral cases also. So once a case, a child or an adult or a patient has bilateral burns, automatically the prognosis gets affected. And because you don't have a normal limbus from where you can later restore the damaged limbal stem cells, so that again decreases the prognosis. And if we look at the other aspects, we have seen that the mean time period that they have given, the duration of presentation is 3 to 10 days in the primary cases that have presented, and secondary cases it's around 2.8 1 to 4 days in the primary cases and 3 to 10 days in the referred cases that they have seen, because that was a tertiary care institute. But again, they have written this as p-value of 0.057. So I think as what Dr. Rohit was mentioning, there was p-value of 0.057 they have mentioned as not significant. But in my opinion, a primary case that presents to a tertiary care center has a definite better prognosis because it's being managed with all the facilities and all the assessment that is being done is standardized. There's documentation vis-a-vis wherever we have to rely on general ophthalmologists or some other place where the primary management was not adequate. So that again skews the prognosis to a certain extent. So that is one issue that I could find. Then they have mentioned in table 1 about the demography that work-related injuries were seen in 7 patients out of 24. So when we talk about work, and that gives us the percentage as 29% of the overall injuries. But if we consider the children are also included in this, whereas less than 14 years, or 13 patients were there out of 24. So I think if we just think about demography that way, then we should exclude those children, and we should then consider that as 7 out of 11 adults. So that makes it almost 64%. From 29 to it becomes 64. That becomes significant. That workplace induced injuries in adults is then the most common part. So that is another negative that I could find. And the timing to AMG was 2 to 14 days. Again, that Vineet was already pointing out that appropriate and adequate medical management, which includes topical steroids given intensively, strong topical steroids to the tune of maybe prednisolone acetate, 1% given at least too early, or things like that, actually create a difference, especially in the lesser severe grades of injury. So that if we can monitor, and there is, as we know, ocular burns and it's the period after post burn is actually a continuum. So we have to document these classifications are not just one day or one time classifications that we have to stick to. Each day or each alternate day, we have to actually make sure that we reclassify them into what grade they have now gone into, and so treat accordingly. So this continuum of post-burn period has to be maintained, and your treatment or your management again depends upon that. So in cases where I would like to do AMG would be those who are in severe burns, those who are responding slowly to the medical management, and or who have not received adequate or immediate care in the primary setting. So that would be my go-to cases for amniotic membrane. And as we know that we don't call it limbal ischemia or loss in the initial phases, because certain part of limbus might even get revived or might recover from the shock post this medical management. So that is another point to be taken care of. Another case where children are involved, I would like to go in for multiple examinations under anesthesia also. So since this was a retrospective study with its limitations that they have mentioned, the standardized assessment, documentation, multiple EUAs and all, multiple observers assessing the cases, different types of cases. I'm not sure how much standardization was maintained, whether the same timings of the visits were documented, were ensured. So how did they take care of the missing data? These are certain negatives that I tried to figure out from the article, but overall, this was a very well illustrated, very well documented study otherwise. Another point that needs to be mentioned is, apart from the corneal epithelial, the conjunctival, the limbal documentation, the adnexal damage is very important, because that again will lead to exposure because of entropion, ectropion, or other lid shortening, lid rigidity, contractures. So again, that has to be totally taken care of. And another most important one is the IOP, or the intraocular pressure. So we have to also monitor the pressures and aggressively treat it. And as we all know, hypotony is an ominous sign, and it signifies poor prognosis. So pressures again are very important in prognosticating such cases. And as we have also seen in additional procedures which were performed for this particular study along with primary AMT. This mentions only 3 tarsorrhaphies were done with the primary amniotic membrane transplantation in eyes. So that again, I personally don't agree with. I always like tarsorrhaphy is one very, very important part of your management of ocular surface burns, and that I really would like to again emphasize upon, because that goes a long way in trying to reepithelize these surfaces. And again, tenonplasty helps because of bringing back the ischemic areas back to vessels here. 2 pointers here in table 3 and 4. Epithelialization time was somewhere faster in grade 5 than 4, and corneal neovascularization again was seen more in grade 4 than in 5 cases of injuries. So again, that might be maybe this amniotic membrane was an overkill in those particular cases, or I'm not sure of how they managed to document that. So these are a few pointers of the negativities of this study. Otherwise, this is an important piece of literature and very good effort, and you've documented it very well. Thank you.
Thank you so much, ma'am. And thank you for reiterating the importance of the continuum of management every day following presentation of ocular surface burns, as well as the role of steroids, and the whole fact that these classifications are not a one-day classification, but a continuous continuum of grading and staging these burns on a regular basis. With that, I'd like to move on to our final expert panel for this evening. Dr. Shuchismita Behere completed her MBBS and MS from JIPMER Pondicherry and underwent phacoemulsification training at the Narayana Nethralaya, Bangalore, and was also appointed as an international scholar for the ISO examinations. Currently, she is working at Dinanath Mangeshwar Hospital in Pune as a consultant in cornea and refractive surgery, with many accolades to her name, which for the scarcity of time, I'm not reading the whole thing out, but I'd like to invite her to talk about the recent advances in this particular subspecialty. With that, I'd like to give the mic to Dr. Shuchismita, ma'am.
Hello, everyone. Am I audible?
Yes, ma'am, you are.
Thank you, Dr. Anujit, for those kind words. Great meeting and excellent presentation, Kirtana and Dr. Aditi. And also great points by Dr. Rohit, Dr. Vineet, and Dr. Purvasha. Thank you, Nupur, for this opportunity. So basically, so as discussed before, I'll just add on a few points which I could find, which we could put under advances, but basically not too much has changed, but the understanding of this entire disease and holistic approach is what I felt has improved a lot in today's world. And second thing is the type of the methodology in limbal transplantation, of course, has evolved from a limbal transplant to the simple limbal epithelial transplantation, allowing us to do it more frequently and more early in the disease process. So I'll just go to So basically, the first thing in the irrigation methods for the eye, as was discussed earlier on by Kirtana, as that it could be either BSS or RL. The other option that has come up now is a diphoterane eye wash, which seems to be available. And it's an amphoteric solution, so you can use it in alkali as well as in acid injuries. It's a hypertonic solution, so it doesn't allow the fluid to enter the cornea. In fact, it prevents the assaulting agent to enter more and helps to egress the fluid and reduce the damage by neutralizing the pH fast in the cornea, and there is no change in temperature on the corneal surface, unlike the other borate buffered solution or phosphate solutions. So as Dr. Purvasha mentioned correctly, the method of the debridement and all are very important, and these are the clinical treatment methods which should be followed under anesthesia, and we need to examine the upper fornix, especially in Lyme injuries, and we could use EDTA also and debride everything, all the necrotic tissue, and do additional procedures as mentioned before. As we know, amniotic membrane, there are 3 varieties now. One is the fresh, which is not being used because of risk of transmission of disease. The wet cryopreserved is what is majorly used. And then there is the freeze-dried. The freeze-dried, the property of the amniotic membrane, like the growth factors, etc., may be reduced. And also it is more stiff and it has to be soaked before using. It doesn't wrap the surfaces as well as your wet membrane. So the wet cryopreserved is what is still being used everywhere for this purpose. We have to wrap the entire, the undersurface of the lids, that is the palpebral conjunctiva, the fornix, and the entire ocular surface based on the staining pattern or the conjunctival and the corneal involvement. Now, how to do that? either you could put a running suture and then and use glue. Sometimes you have to use both, a combination, especially in children. And you could also use the help of this Ryle's tube just for the benefit of the learners who come across these cases. Sometimes you may not have it may be difficult to do the procedure or have other equipment. So you could just use Ryle's tube, which is the feeding tube, which can be size 6 and around 9 centimeters. You can insert one end into the other by making a small neck. This can be placed over the amniotic membrane and tucked into the fornix. But we must make sure that the membrane is complete, and otherwise sometimes the simulacra can form like on either side of the ring. This can be removed after, like whenever the amniotic membrane dissolves, or the procedure can be repeated. The amniotic membrane should be repeated multiple times at times because it's an inflamed eye and the amniotic membrane tends to get dissolved faster. The other options, as we knew, were Procera, and then I came across this amnio clip, which is a stainless steel wire. It's a German device, and then there is a silicone ring with a groove, and the amniotic membrane is put in between these two, and it is clipped and inserted into the fornix. Yet another device, okay, and for some reason the slide is not playing. There is something called as the Amserter by, it was Dr. Bhaskar Ray Chowdhury's device, which has come up, and many people have tried this, which is actually an interesting device, 2 PMMA rings similar to an amnio clip, which can be, which sandwich the amniotic membrane, and you can use a larger piece of membrane and fold it over onto the palpebral conjunctiva as well, which is a very useful and reasonably priced device. So this is another interesting method of treatment suggested by Dr. Geeta Iyer and her team, who have been doing extensive work in this field. They have done the yellow slit in acute chemical injury, presenting within 1 month from presentation, grade 4 DUAS classification and above. So they suggested that using yellow slit, here they have not immunosuppressed the patients. Along with an AMG, they have done yellow slit, and after debriding all the line and following all the other things also during the debridement process, they have found that epithelialization, it promoted epithelialization in an average of around 20 days or so. And they also compared this with just AMG, and they found that the yellow slit group did better. So thank you. These are some things which I could come across.
Thank you so much.
Any significant symptomatic collapse could be equal and aggressive increase in steroid use.
Thank you so much for elucidating all the recent advances. With that, last but not least, I'd like to call upon to summarize from BMMC and Sadarjung Hospital in New Delhi, and then her postgraduate residency in ophthalmology from Ram Manohar Lohia Hospital in New Delhi, and she followed that with her fellowship from Shankar Netralaya in Kolkata, after which she's been working as a consultant in cornea and ocular surface, and actually shuttling between Delhi and Calcutta, working equally hard in both cities currently. Dr. Aditi Ghosh, ma'am, I'd send the mic to you to summarize the whole topic.
Thank you. Well, thank you, Anujit and Nupur and Yosi, for giving me this opportunity to become a mentor to this wonderful, hardworking mentee. Dr. Kirthana, you have truly made me a proud mentor. Excellent, brilliant presentation. And the whole process I thoroughly enjoyed of how we selected. So I think all our esteemed panelists have extremely beautifully summarized all the points. So, but I'll tell the first point that how we selected the article. So it was because of Kirthana's immense interest in ocular surface, which was very interesting to me because I love ocular surface. And it was because she had worked so much during her holy duties at Diwali. So she said, ma'am, I want to do something similar in Eastern India. So that was the reason that as Dr. Purvasha rightly said, you're in the JC showing your results in Eastern India. And so I would just say that Dr. Rohit Modi, excellently, he has just picked the perfect points of sample size and how to define to make the perfect study protocol. Dr. Vineet, I think, as usual, taking the, the most recent advances, he spoke so well, especially the positive thing, and how for a private practitioner, this article might reduce the inhibition of trying to go for a surgical, amniotic membrane use. Many of the private practitioners are a little bit, apprehensive for going towards the surgical or amniotic membrane use. Dr. Purvasha, I don't have words to mention how beautifully, you tried, the perfectionist you are. You tried to take out the very hidden occult negative points of this article beautifully, followed by Dr. Suchi, who, just summarized beautifully all the recent advances that we are using. So I think we have wrapped up all the points of this article. And for all the YOs out there, it is a very good process of, to learn how to build, inculcate all the positive and negative from the JC and formulate a proper study proposal, whether it's your thesis or your future in publication. Thank you so much. Over to you, Anujit.
Thank you so much, Dr. Aditi. That was extremely heartwarming right in the end. With that, we conclude the Journal Club session. I would just like to give some certificates to the esteemed panel as well as the presenter. A certificate for Dr. Kirthana for being an amazing mentee, as Dr. Aditi ma'am just mentioned. And for Dr. Aditi ma'am for being a very understanding mentor, sitting with me as well as Kirthana Di on and on and on over WhatsApp, as well as in the...
Thank you so much.
Dr. Rohit Modi sir for being ever so ready to be the research expert on every Journal Club time and again. Dr. Suchismita Bere for being a part and speaking about so many recent advances which were eye-openers for me as well. I have not heard of half these things in spite of passing my residency just a couple of months back. Dr. Vineet Joshi sir for bringing in the practical aspects for a private practitioner to handle these cases, and Dr. Purvasha Narang ma'am for reminding us again about the continuum of presentation of these cases and how to deal with them. With that, we wrap up the YOSI Journal Club. Once again, for all the YOs out there, if you are listening in and if you want to be a part of the YOSI Journal Club, you can send us your request at the email ID. You can just take a screenshot of this page. And we would love, and we would continue having this all throughout the year, this year as well, just as last year. Since we have covered cornea, we will go for another subspecialty, another mentor, and another mentee next month. And we'll see you all next month. Thank you very much.